There's an antipsychotic where the blood-brain barrier itself is actually working against it, pumping the drug back out through a transporter every time a dose goes in. That drug is risperidone, and the pump is called P-glycoprotein. Stick with me because this one genuinely changes how you think about the rest of the drug. Starting simple, what is risperidone? It's a second-generation antipsychotic, and it's the drug that effectively defined an entire subclass, the serotonin dopamine antagonists, or SDAs. Chemically it's a benzosoxazole, and here's a fact worth knowing. Its own active metabolite 9-hydroxyrisperidone turned out to be important enough that it got developed and licensed separately as paliperidone. So prescribing paliperidone is essentially giving a purified version of risperidone's own breakdown product. Brand name here is Risperdal. Licensing. And this one's genuinely unusual. In the UK, risperidone covers schizophrenia and bipolar mania, as you'd expect, but it also carries two short-term licenses most antipsychotics don't: persistent aggression in Alzheimer's dementia and persistent aggression in conduct disorder in children, both capped at 6 weeks, and both using much smaller doses than you'd use for schizophrenia. BNF's dementia aggression regimen starts at just 250 micrograms twice daily, usual dose 500 micrograms twice daily. In the US, the picture's different. Schizophrenia, bipolar mania, and irritability in autism are the licensed uses, and Stahl notes dementia-related agitation is actually prescribed off-label there, under a black box warning. Don't get caught out here. This is one of the only antipsychotics with any genuine UK dementia license, but it's for aggression specifically, not psychosis, at a fraction of the normal dose, and only for 6 weeks. The mortality warning still applies. 4 receptors matter most here. 5-HT2A, full antagonist, very high affinity, risperidone's headline early mechanism. D2, also a full antagonist, not a partial one, so no built-in ceiling. Alpha-1 antagonism explains a lot of the postural blood pressure drops you'll see, especially early on. And alpha-2 antagonism is a bit unusual for an antipsychotic. It may modestly boost noradrenaline release. The real teaching point here: risperidone's atypical behavior is dose-dependent. Stahl describes it as having somewhat reduced motor side effects at lower doses. Practically, that means at low doses it behaves like a proper atypical, mostly serotonin blockade, but push the dose up and D2 blockade becomes more dominant, and so does EPS risk, which is exactly why BNF itself flags doses above 10 mg per day as needing a benefit outweighs risk judgment. Now let's map that same mechanism onto the 4 dopamine pathways. Same story as any antipsychotic, but risperidone has a distinctive twist on the last one. Mesolimbic blockade calms positive symptoms, that's the straightforward one. Mesocortical is more nuanced. Full D2 blockade here risks worsening negative symptoms, but 5-HT2A antagonism partly rescues that by boosting cortical dopamine release. Nigrostriatal blockade drives the dose-dependent EPS we just covered, becoming prominent above about 6 mg a day, and tuberoinfundibular is where risperidone really stands out. Its active metabolite gets pumped out of the brain by P-glycoprotein, so more of it circulates peripherally, right where the pituitary sits outside the blood-brain barrier, which is a big part of why prolactin elevation is so pronounced with this drug. Same brain outline as always. Midbrain dopamine cell bodies branching to 4 places, mesolimbic pathway up into the limbic system. Blocking D2 here helps with hallucinations and delusions. Mesocortical pathway forward into the frontal cortex, more nuanced for risperidone because serotonin blockade there is doing some rescue work. Nigrostriatal pathway down into the striatum, movement control, and this is where the dose-dependent EPS problem lives. And tuberoinfundibular down to the pituitary. Remember, this pathway sits outside the blood-brain barrier, which is exactly why it's so exposed to risperidone's prolactin-raising effect. 4 receptors that define this drug clinically. 5-HT2A first, very high affinity, full antagonist. The receptor risperidone hits hardest and fastest. D2, also high affinity, also a full antagonist, no partial agonist ceiling to soften things. Alpha-1, moderately high affinity, antagonist, that's your orthostatic hypotension risk. And H1, moderate affinity, antagonist, contributing to some sedation and weight gain, though less than the more histamine-heavy drugs like olanzapine. Now the receptors shaping the side effect profile. Alpha-2 antagonism is genuinely a bit unusual for an antipsychotic. It may modestly boost noradrenaline and serotonin release, though that's a minor contributor, not a headline effect. 5-HT7 antagonism gets mentioned in some mood and cognition literature, again minor. D1, D3, and D4 affinity are all fairly low, so they're not doing much independently. And muscarinic M1, essentially no binding at all, which is exactly why you won't see the dry mouth, blurred vision or constipation you'd get with olanzapine or clozapine. PK time, starting with absorption. Risperidone gets absorbed fast, peaking in the blood at around an hour after a dose, quicker than a lot of other antipsychotics. Absolute bioavailability sits around 70%, and food doesn't meaningfully change that, so patients can take it with or without meals. Unlike some antipsychotics that just diffuse across the blood-brain barrier, risperidone and its active metabolite are actively pumped back out by P-glycoprotein, one of the most potent substrate relationships known for any antipsychotic. Knockout mice without this pump show brain levels around 10 times higher than normal. That tells you how limiting this really is. Clinically, drugs that induce this pump, like rifampicin or carbamazepine, can drop brain exposure further, while inhibitors could theoretically raise it. And here's a genuinely interesting angle. There's a hypothesis that chronic cannabis use upregulates this same pump, which might partly explain why antipsychotics sometimes seem to work less well in patients who use cannabis heavily. Distribution. Protein binding is high but not extreme. 90% for the parent drug, a bit lower at 77% for its metabolite. Half-life is where it gets interesting. The parent compound alone has a half-life of just 3 hours in fast metabolizers, stretching to 20 hours in poor metabolizers. A big genetic difference. Here's the reassuring part though, because the metabolite is just as active as the parent, the combined active moiety half-life comes out at around 20 hours either way, so fast and slow metabolizers end up in a similar clinical place. Using the 4 to 5 half-lives rule, that puts steady state at roughly 4 to 5 days, much faster than some other antipsychotics whose active metabolites take weeks. Metabolism runs mainly through CYP2D6, the enzyme with that well-known genetic polymorphism, so some patients are naturally fast metabolizers, and some are naturally slow. That matters more for interactions than baseline dosing, since we just said the combined active moiety washes that difference out. There's a small secondary pathway to N-dealkylation. The active metabolite 9-hydroxyrisperidone is just as potent as the parent drug. For excretion, a real point of difference from some other antipsychotics, about 70% leaves via the kidneys, only a small amount via feces. That makes renal impairment a bigger deal here than for a drug that's mostly cleared through bile. Hepatic impairment matters too, but differently. It increases the free, unbound fraction of the drug because protein binding drops. Let's nail the partial versus full distinction, because this is exactly where risperidone differs from some newer antipsychotics. Every receptor action here is full antagonism. D2, 5-HT2A, alpha-1, alpha-2, H1, all full blockade, no partial agonism anywhere on this list. That's an important exam distinction. Don't assume every modern antipsychotic works via partial agonism. Risperidone is a classic full antagonist, serotonin dopamine antagonist drug, and that's exactly why it doesn't have the built-in ceiling effect that protects partial agonists from things like dose-dependent EPS and prolactin elevation. Dosing Part 1. The practical side. Adult schizophrenia dosing. 2 mg a day on day 1, stepping up to 4 mg by day 2 if tolerated, with slower titration appropriate in some patients. The usual dose is 4 to 6 mg a day, and BNF allows up to 16, but it's explicit that anything above 10 mg a day should only be used where the benefit is judged to outweigh the risk, not as routine practice. Worth knowing too, mania has its own separate titration. 2 mg once daily, then increasing in 1 mg steps, with a usual dose of just 1 to 6 mg a day, generally lower than the schizophrenia range. Food timing isn't an issue, take it with or without meals. Formulation-wise, risperidone is genuinely flexible. Tablets, a dissolving tablet, a liquid, a fortnightly depot injection, and even a newer once-a-month version. If you need to come off it, standard gradual tapering applies, same as any antipsychotic. Now let's cover the depot regimens properly, because formulation availability isn't the same as knowing the actual dosing, and this is where BNF and Maudsley genuinely complement each other. BNF gives you the official Risperidone Consta regimen. If someone's stabilized on oral risperidone at 4 mg a day or less, you start at 25 mg every 2 weeks. Above that, you start at 37.5 mg every 2 weeks. You increase at intervals of at least 4 weeks up to a maximum of 50 mg every 2 weeks, and critically, oral cover continues for the first 3 weeks because the depot simply isn't releasing meaningful drug yet. Maudsley explains exactly why that 3-week rule exists. After a last dose, plasma levels don't even peak until 4 to 5 weeks out, stay therapeutic to around 6 weeks, and don't reach zero until 7 to 8 weeks. That's also exactly why Maudsley now says Consta is rarely started in practice. It's been overtaken by simpler options. Risperidone is one of them. Same 2-weekly injection, but only 7 days of oral cover needed instead of 3 weeks, and you can switch directly from Consta without any oral bridging. The first Risperidone dose is simply given 4 to 5 weeks after the last Consta injection. Risperidone ISM, branded Ocadi or Risvan, goes a step further. A monthly injection, no loading dose, though you do need 14 days of confirmed oral tolerability first, and it's not suitable if someone needs the 2 or 6 mg oral equivalent doses, or if creatinine clearance is under 60. And in the US, Prescribing is a subcutaneous monthly option. 90 mg is roughly equivalent to 3 mg a day oral, 120 mg to about 4. One more thing worth remembering, hepatic impairment doesn't just apply to oral dosing. Maudsley gives specific depot starting doses for severe hepatic impairment too. Consta can start as low as 12.5 mg, Ocadi at 75 mg, Prescribing at 90 mg monthly, each built around first confirming a lower oral dose is genuinely tolerated. In the elderly, BNF's guidance is to start at half a milligram twice daily and titrate up in half milligram steps, toward a target of 1 to 2 mg twice daily. For hepatic and renal impairment, BNF keeps this refreshingly simple. It doesn't split patients into mild, moderate and severe bands the way some other drugs do. The instruction is just, halve the usual dose and titrate more slowly, full stop, whether the impairment is hepatic or renal. On interactions, strong CYP2D6 inhibitors like fluoxetine or paroxetine raise parent drug levels, so you may need to trim the dose. Though because the active metabolite is less affected, the overall clinical impact is often smaller than expected. Enzyme inducers like carbamazepine or rifampicin work the other way. They can knock the combined active moiety down enough that you might need to double the dose, and just as importantly, bring it back down again if the inducer is ever stopped. Contraindications and special populations. The only absolute stop is hypersensitivity to the drug itself. BNF also flags some specific cautions worth knowing. Avoid in acute porphyrias. Take care around cataract surgery because of a recognized risk of intraoperative floppy iris syndrome. Avoid in dehydration. Avoid in dementia with Lewy bodies specifically, and be cautious in prolactin-dependent tumors. That last one follows naturally from everything we've said about this drug and prolactin. Pregnancy and breastfeeding both follow the same BNF instruction. Use only if the potential benefit outweighs the risk. Breastfeeding isn't an outright avoid, but BNF does confirm a small amount of the drug is present in milk, so that risk-benefit call needs to be made deliberately, not assumed away. Dementia-related psychosis carries the same boxed mortality warning as every antipsychotic, and full psychosis is not approved anywhere. Remember, the UK exception we covered earlier is for short-term aggression specifically, not psychosis generally. And for children, the UK license covers conduct disorder aggression from age 5, short-term only, while the US picture is broader. Schizophrenia from 13, bipolar mania from 10, autism irritability from 5. Monitoring. The same backbone as any antipsychotic. Weight, glucose, lipids, ECG, liver and kidney function, and movement monitoring with AIMS. Two things deserve extra emphasis here. Prolactin needs particularly close attention. This is genuinely one of the more prolactin-raising drugs in the class, so don't treat that as a routine tick box. And blood pressure, especially early on and after any dose increase. Because of the alpha-1 antagonism, some patients get real postural drops and even fainting, which is exactly why the titration schedule starts so cautiously in vulnerable patients. Side effects. Using the same standard BNF and MHRA frequency system, very common is 1 in 10 or more, down to very rare below 1 in 10,000. Now, BNF actually groups common and very common together for risperidone rather than splitting them, and there's a genuine surprise in the list worth flagging directly. It includes headache, GI upset, sleep disorders, sexual dysfunction, and a long list of general systemic effects, but it does not name Parkinsonism or akathisia specifically in that band, and it lists weight decreased, not weight gain. That doesn't overturn the wider evidence base. EPS and weight gain are both extremely well documented for risperidone in the trial literature and in STAL, but BNF's own consumer-facing list uses broader terms, and for this particular formulation entry, genuinely does list weight loss rather than weight gain as the very common finding. Worth knowing exactly what your source says, rather than assuming it matches the popular narrative. Breast changes and cardiac conduction effects sit in the uncommon band, tying back to prolactin and quart effects respectively. How does risperidone stack up against the rest of the field? Weight gain and metabolic risk sit in the middle. Stahl describes it as a moderate amount of risk for weight gain and dyslipidemia, worse than aripiprazole or cariprazine, better than olanzapine or clozapine. Prolactin is where risperidone really stands out. Stahl states plainly that it raises prolactin levels even at low doses, and Maudsley notes hyperprolactinemia is usually worse with risperidone than with most comparators. QTC and sedation are both low to moderate, nothing alarming. EPS and akathisia sit moderate to high and are clearly dose-dependent, and sexual dysfunction is high too. Maudsley links this directly to prolactin, ranking risperidone above haloperidol on this measure. Two angles to finish the negative facts picture. First, NMS. Yes, it's been reported with risperidone, same as every other antipsychotic, so never treat any drug in this class as exempt. Second, formulations. And this is the opposite story to some other antipsychotics. Risperidone is available in almost every format there is. Tablets, a dissolving tablet, a liquid, a fortnightly injection, even a newer monthly one. Very little missing here. What's worth remembering though is what it's not licensed for. Full dementia-related psychosis anywhere, autism-related irritability in the UK specifically, even though that's an FDA-approved US indication, and adjunctive treatment for depression. Interactions in 3 groups. Strong CYP2D6 inhibitors, fluoxetine, paroxetine, quinidine, raise the parent drug's levels, so dose reduction may be needed, though because the active metabolite is less affected overall, the clinical impact is often more modest than the parent drug numbers alone suggest. Enzyme and P-glycoprotein inducers, carbamazepine, rifampicin, phenytoin, work the other way, dropping the combined active moiety enough that doses sometimes need doubling, and just as importantly need bringing back down if that inducer is ever stopped. 2 general cautions to remember too. Combining with other CNS depressants or alcohol adds to sedation, and combining with antihypertensives can worsen that alpha-1 driven drop in blood pressure. Quick fire round. Is risperidone a partial agonist at D2, like cariprazine? False. Full antagonist throughout. Does it hold a genuine UK dementia license? True, but narrow and short-term for aggression, not psychosis. Does it cross the blood-brain barrier freely by passive diffusion? False. It's actively pumped back out by P-glycoprotein. Is it one of the highest prolactin antipsychotics? True. Is its EPS risk flat regardless of dose? False. It rises disproportionately above about 10 mg day. Is CYP2D6 its main metabolic pathway? True. Does it lack a long-acting injectable option? False. It has 2. And is it NMS exempt because of its mechanism? False. Always false. No antipsychotic is exempt. So back to where we started. Which antipsychotic gets actively pumped back out of the brain by its own transporter? Every single dose. Now you know. Risperidone via P-glycoprotein. And now you know exactly why that matters for interactions, why its prolactin profile is one of the worst in class, and why its UK dementia license is a genuine exception but a narrow one. If this helped, subscribe for the rest of the pharmacology series and drop a comment.